I'm Marvin Malik, one of the preceptors for the Northern New England Health Policy Internship Program. And today we're going to look at a piece of legislation that was uh, passed by both houses of of Vermont's legislature and signed by our governor just in this last legislative session. It's not a small task to get legislation passed, so we're fortunate enough to have three of the protagonists in this effort joining us here today. So I'm very thrilled and honored that that's the case. I'll first introduce Katie Marvin. She is a family practitioner in working in Stowe, Vermont for 15 years. Went to medical school at the University of Maryland, did a residency at UVM in Burlington, Vermont, as well as an obstetrics fellowship out in Seattle. She's especially interested in pediatric and adolescent health, addiction medicine, and serves as an advocate. And in fact, is the president of Vermont Medical Society. I think that's the correct title, and is also involved in the American Academy for Family Practice. She has three kids. Her husband is a sugar maker, and they spend a lot of time outdoors. And I don't really understand how it's conceivable to do all that within one span of one life, but that's my intro on Katie. Alyssa Black is from Essex, Vermont, is in her second term in Vermont's legislature in the House. As is the case with me, she was born and raised in Western New York and then attended the University of Vermont and has been living here in Vermont for nearly 35 years. And she's been working for many years in a local family practice, a very large family practice in Chittenden County, Vermont. And she spent a lot of time throughout her professional life interested in working on a variety of initiatives to strengthen the healthcare system. So thank you for coming too. And last but by no means least is someone whose work I admire also. Jessa Barnard is currently the executive director of the Vermont Medical Society. She's a native of Bennington, Vermont, earned a bachelor's degree from Dartmouth, and then went out west to Stanford, where she earned her law degree. She's has done some advocacy before spending really the last probably 15 years, if I'm adding it up correctly, working first at the Maine Medical Society, Maine Medical Association, and more recently at the Vermont Medical Society as its executive director, and that's now for 7 years. And I just want, Jess is a fabulous advocate, and Alyssa can comment on that later in the session, but I'm really fortunate to have her as well. So really, all three of you, thank you so much for joining us. I'm really pleased. If we could start out perhaps by discussing the legislation itself, and maybe Representative Black, if you can tell us what's in the bill, and then maybe later we'll get into a little bit about how it is that it passed this year.
Sure. So first of all, thank you for having me. So the bill was H766, and I'll bet Jessica could tell you the act number, but I couldn't, because once it's out of the legislature, I never pay attention to the act numbers once it gets signed. So the bill started and frankly sort of ended pretty close to how it started. We had a lot of budgetary constraints this year, and yet we're challenged by our demographics and particularly lack of primary care in our state. So, the thinking was, what can we do that actually isn't going to cost us any money or cost the state or the legislature any money, but that we could support our healthcare system. So the bill contained several provisions. The first provision is it really puts some limits on step therapy. And can I assume that everybody understands what step therapy is?
No, I think we should explain it.
So essentially, step therapy is the process where an insurance company requires you to go through we're really mainly talking about prescription drugs here, where they'll make you try things on their formulary, tier 1, tier 2, tier 3, and that you have to try and fail on these medications before the insurance company will then approve you for the medications that are not their preferred drugs. Now, of course, formularies change all the time, has more to do, frankly, with the pharmacy benefit managers and, whatever particular preferred medications they're choosing at the time. You would think it would be generics, but it's not even always generic drugs. And basically what this provision does is it limits the insurance company's ability to deny something without you, if the physician has a reason for not trying a certain medication. So they do not have to go through step therapy. If somebody has tried and failed already on a drug in the same class, or if there is a reasonable belief due to multiple reasons that this patient of yours will not be successful on this medication. So that's really important. We had the next section of the bill had to do with claims edits. Nobody cares about this except for me because I'm a coding guru. So coding is my jam, but we actually had a situation here in the state of Vermont where one of our payers had a contract with a third-party claims administrator, and they started doing what's considered to be prepayment coding edits, where if a correctly coded claim comes in, that they can flag that claim and then ask for medical documentation to prove that you provided that service. And it really disrupted our healthcare system here. It was, thousands and thousands of claims were just not being paid. There was really no mechanism put in place to appeal. It started where you'd fax to a fax number, and the fax number they provided wasn't even a working fax number. It was just kind of a nightmare. So what this did, and I don't know if anybody here knows about coding. If you're all med students, you haven't learned it yet, but believe me, by the time you get done, you will know all about coding. What we did in this was we essentially aligned coding edits and to currently what Medicare does. Medicare has very exacting standards when it comes to claims edits and coding edits. And, if you start looking at all payers are just, everybody uses different suggestions, different coding requirements. And it was really, the intent was to align everybody so that everybody's working on the same rules under the same page, to sort of make the administrative burden of sending claims in. And it also banned the use of prepayment coding edits, except for in very certain circumstances, such as really high dollar claims, and suspicion of fraud, waste, and abuse. Then we eliminated.
Alyssa, I'm going to
Oh, I'm
interrupt you
sorry.
just for a second.
Sure.
I just want to say that I didn't know about this before, and believe me, I am like a junkie in reading this kind of stuff, and it never ceases to amaze me. The administrative complexity in the U.S. healthcare system never ceases to amaze me, and this kind of thing where what you're discussing, which must be a nightmare for the administrative staff of physician practices and around the country, it sounds like. And people don't even know about this, and it just astonishes me. Anyway, I'm sorry to interrupt you. So go ahead with the final part of the bill.
No, that's okay. I will just say that actually one of the benefits of this particular section that I was talking about is nobody else understands it, so it sort of sailed right through. Um, so um, then so really exciting was essentially we eliminated for commercial payers, and I have to say that the commercial part of the market that we actually have legislative control over, self-insured, we can't do anything about Medicare, although Medicare doesn't require prior authorization. But what we did was we eliminated prior authorization for all primary care providers, except for in the cases of out-of-network services and for prescription drugs. And this is really important because the majority of the burden of prior authorizations really does fall on primary care. And then we did some work around prior auths that still are able to be required, just eliminating or putting some barriers on the time that an insurance company has to respond. An urgent request has to be responded to now in 24 hours instead of 48 hours. All prior auths have to be responded to within 42 business days. And if you need additional information, the insurance company has to get back to you within 24 hours to say we need additional information. So it makes it so that they can't just stretch out this prior authorization process, indeterminately for forever. We also did, I think, a really big one, and this is coming from somebody who has done thousands of prior auths in her lifetime. Every single year, an insurance company requires, if you're on a certain medication, no matter how long you've been on that medication, they require that you do a prior authorization once a year. So all of this happens usually January 1st. So if you're a provider, you have hundreds and hundreds of patients that you have to do a prior auth request for a drug that they have continuously been on, a chronic stable medication, and they all get approved, but you still have to sort of jump through that hoop. So we did limit it. So we limited that prior auth can only be requested on the course of treatment or 1 year, whichever is longer. And if it is a continuous stable medication, that it only needs to be every 5 years. So if you think about that in terms of if you're a provider, every single patient who's on a medication, we've just taken 5 of them and we've eliminated 4 of those 5. So that's really important. And then there are some reporting requirements. We faced an awful lot of information or lack of information, I should say, when we were taking testimony on this. The insurance companies would throw out, numbers of how much they thought that this would cost them. The numbers were sort of continually changing, not quite sure where the information was coming from. We know that the burden on providers is very onerous. Multiple staff members that do nothing but meet insurance companies' requirements. And so we have a pretty robust section in this bill to report back to us in 2 years to let us know the impacts of this. And that's really kind of the bill in general. We've done an awful lot of work around prior authorizations I've only been there for 4 years, but I was really grateful. I had an awful lot of reports and studies and working groups to pull information from, because it seems like for years and years and years, we've known this is an issue, but we really haven't been able to, make any substantial changes. We just sort of keep asking for more information and more information. And so really, I think this year we were just like, we're done with that. We're going to give it a try. We're going to look back in 2 years. We're going to see how it works.
Well, I would think it's possible that your role as vice chair of that committee has helped it along, that you know about this and you've been there now in your second term, so you helped it along. But before we go on, I guess I'd like to get the physician point of view on this. So Dr. Marvin, if you don't mind, telling us why you spend so much time advocating for this and what your thoughts are. When you speak to other doctors, what are you hearing about the elements of this bill? What's most important and why?
Yeah, thank you. And thanks to everyone for being here. It's a fascinating, you're like an incredible group of people from all over the country, sounds like. Um, One of my biggest drivers to support this bill was to decrease provider apathy. So you guys are all very smart people, and imagine that you were an expert in something and you had a group of people that were trusting your expertise in this field. Like, I don't care what it is. Maybe you're like you play the violin, you're a soccer coach, whatever. And you're trying to like be trustworthy and knowledgeable about a topic. And so you give advice, and then there's this little bird over here going, no, you can't do that. Or you're not allowed to, or you can't do it yet, or you have to wait 10 days, or whatever it is, the patients start to like sort of wonder who to trust. Do you know what you're doing or not? Like, we're trying to promote family medicine and primary care because it is such an important field. It's such a rewarding field. Um, but to have this constant nag of somebody like, looking over your shoulder, sort of telling you what you can and can't do when A, as Alyssa said, it's going to be approved, and B, it's the right thing because you've been to school forever to learn it. So decreasing provider apathy, I think, will decrease burnout. All of you work amazing hours. You can stand up to any sort of amount of pressure. You've proven yourself intellectually. It's not the long hours of medicine that burn people out, it's apathy. And so I think that's really one way to look at my motivation is I see decreasing apathy as an important way to improve retention. So as first year med students, you'd also recognize like some of the basics. Like let's say you had somebody in front of you who had the worst headache of their life. It's sort of like elephant on my chest in the verbiage you learn in school, right? You know what to do. You get a head CT. It's like automatic. But for me to get a head CT same day in my office would not happen. I could order it. I could call the ER. No, I could order it. I could call the hospital. I could schedule it. They'd probably put it in the schedule, but they wouldn't do it until they knew the prior auth was done because then the hospital might not get paid. Alternatively, I can send this person to the ER, charge them another $800 if they're Cigna or MVP or Blue Cross or something, and then they'll get it done because there really aren't prior authorizations. If you talk to an ER doctor, they don't even know what these are. Well, I don't know. I could be wrong about that, but I don't think they know as what they I don't think they have to deal with them as much. So anyway, point being, when I have a patient in front of me with something where I really know there's an urgent need for a study, and I look at them and say, you went to the wrong place. It's not their fault. I'm actually really glad they came to me for something like this. This is a big deal. They should trust me with this, and I know how to deal with it. I can't, and I usually end up diverting them, costing them more, costing the system more, slowing down the ER when I could have just ordered this study and gotten them what the test they needed, right? So the way I look at it, one thing that Alyssa said is really important. Most prior authorizations do get approved, and we do have teams that do this for us. I don't want you guys all to think I'm spending all day doing prior auths. I actually am not. There's people in my organization, thank goodness, to do this for me, but I work for an organization big enough to have that. If I worked for myself, I would have to do them myself. Um, but if they're going to get approved anyway, and they just slow down care, and they actually increase costs because you end up diverting people or having all these workarounds, like what's the point? Um, and so I think when we pose it that way, we start to get the ear of legislators who say, wait a minute, this might be making you more apathetic, costing the system more, slowing down care. And if this was me, I'd want you to order that head CT same day, not like let it wait 2 or 3 days or send me to the ER. So when you put things in these very common sense, like clear example terms, it all kind of makes sense. Similarly, let's say you have a kid in front of you with asthma. They use an albuterol inhaler 3 times a week. To do a prior authorization for them every January seems a little ludicrous, but it's required. Come on. Who made this rule? Like we've kind of passed this tipping point of unnecessary work. There are times where I kind of use the prior authorization to my advantage. I've got some guy who skis 80 days a year. He tweaks his knee. I do an exam. I think his exam's actually pretty reassuring. He doesn't have a story for a major ACL issue. I think he's actually going to be okay in 3 weeks with some physical therapy. So I kind of blame the prior auth. I say, we could get a prior auth and an MRI, but it'll take a while. Why don't you do PT for a week or two first and see how you're doing? And I use this prior auth as this like excuse to delay the study that they really want, that they're coming and basically asking for, and kind of get them gently down this physical therapy path, which is more evidence-based anyway. But very often the patient at this point honestly just wants the MRI, which that's a whole nother story. So why is this important to providers is I think that we recognize that medicine's expensive, more expensive than it should be in this country. But primary care across the board already orders fewer expensive tests, already provides more cost-effective medicine, and medical care than any other field. It's been proven in every state. So we order fewer tests, we order fewer designer drugs, we tend to stick to generics and evidence-based practice instead of ordering things that we don't need to do. So we're already more cost-effective. To put more administrative burden on the field of medicine that's the most important, the most in need, and the most already sort of at risk of more burnout just doesn't make sense. So when you kind of put all these things on the plate and you say, look, we're doing more harm than good with this administrative burden, I think people start to listen. Like, you are losing a lot of people, not because of the long hours, not because of the work, it's because of this feeling of apathy and lack of trust. And honestly, it's delaying care and just burdening ERs. So that was my perspective, and that's how I tried to explain it in papers and letters. When I met with the governor, I basically said, like, what really worries you about this? And he said, I'm just really worried you're going to order more tests. Like, you're just going to go crazy with your test ordering. And I was like, I'm a family doc. I don't order a test unless it's needed. And when I order it, it's needed. So, and I know that sounds a little biased, and it probably is, but it's a little bit based on enough evidence for me to say it out loud. So anyway, I was like, I'm not going to order any more tests. I'm just going to send fewer people to the ER for tests that I can't order that day. And he's like, oh, that's interesting. So that was my perspective. That's how I kind of advocated for it, and I was very happy with it. I think that it'll be interesting to see how it plays out. It'll be interesting to see how the studies are done. As Alyssa also said, it really only affects our private sector. It doesn't apply to people on Medicare or who are self-insured. And it really only applies to imaging for the most part. It doesn't apply to medications, and it really only applies to primary care, which was a pivot they made sort of mid-session. It was going to apply to all fields, and they changed it to primary care without really consulting. At least I didn't hear much about it. It just sort of changed. So that was interesting. But that's my perspective for this part of the talk.
Katie, I want to respond. I found it very interesting that you used the word apathy because I've been on the, I've worked in primary care as well as an internist, and I don't feel apathetic. I feel like really irritated. Like I can, in primary care, you spend so much of your time treating hypertension, and I felt like, okay, if we wanted to raise someone's blood pressure, here it is, prior authorization, do it. Like I'm trying to get through my day, focusing on, and you have to treat so many different problems for, that your patients have, and I get through a visit and I've got it all in my head so that all the interactions between the drugs and the illnesses they have, it seems to be right. And then 2 hours later, I'm doing the very same thing with another patient, and I got to go backward and speak to some doctor or arrange a time to speak to some doctor who's working for this insurance company because, the receptionist team couldn't get the thing approved without a physician discussion. And the whole thing is just, I feel like it's there to raise my blood pressure, and it really, is just one factor that leads to burning out. And it's one of the reasons I became a hospitalist, is doing this to primary care. Like you're right, that primary care is probably the most cost effective and of the greatest significance to public health of all the specialties, without doubt. And yet it's just so oppressive. So yeah, I was impressed also that the legislature focused on primary care for this one. Like finally you're doing something to help, in the trenches of primary care.
Yeah, it
I don't
felt
know.
like a
I
little pat on the
imagine
back.
yeah, I imagine that you must have gotten a lot of positive feedback about the bill when
Oh,
you
I mean,
talk
we
to
had a
other
party
doctors.
in our office with a cake.
Really?
Somebody has their hand up.
Yeah, I'm Serby. I actually had a question about kind of the medical necessity of prior authorization. To my understanding, it's like a kind of an insurance requirement to just cover services. I just am not sure if you think we should, this might be a little radical, but like try to eliminate prior authorization, like advocating for that, or is it like medically necessary? Do you think that we have that kind of check in place? Yeah, I just wanted to hear your perspective on that.
Well,
Katie, do
I'm
you want
trying
to
to
go ahead?
imagine what would happen if they didn't exist at all. You know, as Alyssa said, she's done more prior authorizations than I have by 100,000 times. And I'd say most of them, Alyssa, get approved, right? Like how many actually get denied?
Um, well, it's interesting. That well, I'm not sure I'll talk about that because that sort of gets into the weeds of getting accurate information. But when something is medically necessary, I have never, ever seen a prior approval not ultimately be approved. Um, a step therapy actually doesn't just apply to medications. It can apply, in the example that Dr. Marvin gave about the skier wanting the MRI of the knee, um, prior authorizations if it in the clinical judgment of that physician that person needs an MRI based upon, physical findings, exam, most often that person will ultimately get that approved. One of the requirements with MRIs in particular is that you have had to try and fail on physical therapy. Now, Dr. Marvin would order physical therapy if she felt as though this is maybe, something that evidence-based that would best be, in her clinical judgment, would be helped with physical therapy. But the insurance companies make you do the physical therapy regardless. So then you can have somebody for 6 weeks doing physical therapy on something that really needs an MRI. And of course, you can't even get an appointment with a specialist until you've had the MRI because they are so backed up that they can't see people unless they know that, there might be even surgical candidates or something like that. So, it bogs the whole system down. Is it medically necessary? I can't think of, and for full disclosure, by the way, I was in healthcare administration for 26 years. However, I did leave last year. I'm doing a part-time gig where I'm at right now. But when I started working in healthcare, there was no such thing as prior approval. There just wasn't. And did we order more tests then? Did we, was there incentive to order unnecessary tests? That was the reasoning behind the whole prior authorization process that the insurance companies, have continually expanded and expanded over the years, that they were somehow this stopgap measure on exploding costs. But I would say that if you look at the trajectory of healthcare spending, I'm not sure it's controlled many costs. They would say it has, but did we order more things when there was no prior approval? Did people receive medically necessary treatment? I would say that they probably did. I would say that right now people are not receiving necessarily timely and medically necessary treatment because of the prior auth process.
Would like to respond to Survey's question. The data, there was an intensive study by the Office of the Inspector General of Health and Human Services. I think it was 2018 or 19, I'm not sure which year, and they found that year there were 35 million prior authorization requests. 2 million of them were denied. And I just want to say that Dr. Marvin's point that it's so annoying when it's going to get approved anyway is true. But the other 2 million, that minority, whatever it is, 6% that are disapproved, also can end up giving you a whole lot of more work. So I don't know which is more annoying. I just want to throw that in. In 41 of 50 states, they've contracted out, their Medicaid programs are contracted out to private insurers, and they have a denial rate that's more than twice as high as it is there are more than twice as many prior authorization requests and twice as many denials for those Medicaid managed care programs. We don't have that in Vermont.
There's a
Go
couple
ahead.
questions, Jessa and
Yeah,
Marcellin.
Jessa.
I just wanted to chime in with a little data that I think helped our work on this bill and building the case leading up to it is actually that our Vermont's Medicaid program, which is not contracted with commercial but run in-house, actually eliminated a number of prior authorizations during the COVID-19 emergency and then studied the impact on ordering of, dental services, DME, durable medical equipment, and imaging, and did not see a change in ordering. So, that I think is a really important, it was interesting going through the legislative session, the commercial carriers spent a lot of time trying to argue how different they are from Medicaid and why that data did not apply to them. But I actually think it's the perfect example of, these sort of have come in place over time for a number of reasons that Alyssa mentioned. And one other argument I've heard for why there's been this explosion of prior authorizations is that now that insurers can process them electronically, it's a lot faster and cheaper for them to put them in place when they used to actually have to process paper by hand. Alyssa, maybe it was you who gave this your theory of why we've seen sort of this exponential increase in just the number of procedures, drugs, et cetera, subject to prior authorization. It's very easy to put them in place. But we have, I think, a real life example in our Medicaid program. And, most talking to our members, folks aren't looking, clinicians are not looking at which insurance type you have when you're recommending what you think this patient needs who's sitting there in front of you. So if, whether it's Medicaid or a commercial payer, you're not saying, oh, go get this MRI because it'll be, how much we get paid for it or how much the imaging center gets paid for it. You're looking at what is the appropriate or process, the next step for this patient. So just wanted to, we certainly tried to use that evidence during the session.
I think Marcellin had a question.
Yeah, Marcellin, go ahead.
Yeah, I have a kind of like a follow-up to Serby's. I guess I'm just a little bit confused about the finances of it, but if the intention for implementing prior authorization was to save money from unnecessary tests, how is this, I'm just kind of curious, how is the solution to spend more money on administrative healthcare? Are they actually saving any money after, paying all these people and implementing this process?
It's a good question, and I don't think the finances are clear enough for anyone to, we were getting quotes from insurers that were all over the place about how much this would raise rates, and it's different for different insurers, it's different for different populations, it's confusing. It's almost like this emperor's new clothes situation where you just have no idea what's happening and don't know how to drill it down. And And your logic is sort of the logic that we follow. Like, this doesn't seem to be decreasing costs. I mean, to blow this up a little bit, my perspective has always been the big increase of cost in this country has not been the ordering of tests or medications. It's just the lack of primary care because it's missing in so many places. We don't have that foundational level that provides the least expensive, most efficient care instead. And I saw this during COVID. I had a lot of people move up to Stowe from inner cities, and they sort of wanted 3 or 4 specialists right off the bat, very healthy people for things that we could manage all in one visit. And they looked at like completely baffled that that was possible. And so that's the kind of mindset that's gotten sort of under the skin of this country, where people have this very fragmented, very expensive care. So prior auths for medications and imaging, that we're all going to order what we're going to order. It's the right stuff to order. But the fragmentation of care is really very expensive. And that's like not being discussed. So, it's always been sort of a joke that I've mentioned to Jessa, like, not that I want any more prior auths, but there really should be step therapy to go to specialty care. But then we get into, I think that happened in the 80s before I was practicing, and I don't really want to rewind time because it sounded like that was also a nightmare. But this is the kind of stuff that, talking about it at a grander scheme and thinking about, like, where are we saving money? Where are we spending money? What's actually helping our population get better? And bigger things, like we actually have a pretty unhealthy population in this country, unfortunately. And so the preventative health care and the public health measures that just could try to sort of work on some upstream issues just to help people have better health is going to really save the most money.
Alyssa, go ahead.
I just wanted to expand on, the information, and it's all sort of wrapped in enigma. But the information that we were getting from the payers, I think that something that got lost in all of this and was a little frustrating was that, like all the payers in our state, they're nonprofits. But the keepers of the data that they were trying to get for us regarding costs, those are coming from third-party administrators, and those third-party administrators are not nonprofits. They are most often owned by some of the largest insurance companies in the US, and they are for-profit. And that is, so, and you hear these denial rates of, well, 6%. And you would ask the question, well, is it saving, or, is it really containing costs? The 6% from somebody, again, who has done thousands of prior auths in her life. People don't understand the process of since the automation of prior auths and sort of downloading the administrative burden to the provider and away from the payer, what has happened is that you can go through an entire prior approval process online, because it's all done online now, and you get to the end and you get your decision at the end. And once you've put everything in, you don't get to go back and change it. So you might have put in the wrong diagnosis code. You might have had some information about somebody trying and failing something that administrative person looking at the person's chart didn't catch, because we're not clinical. And that is a denial. Once it's denied, it's always denied. In order to correct it, you have to go back and you have to start a new one. So when they start giving numbers like 6% denial, and I kept asking them this, what about the ones that are subsequently approved, either next day, week later, month later? How many of those? And they could not come up with the numbers, because the numbers are given to them by the administrators, the third-party administrators who administer these plans, who, frankly, the incentive for them is to make make their work seem as though it's saving the insurance company an awful lot of money. And I wanted to give one example, and I never could get an answer on this, but from someone who's done this a lot. So imagine, if you will, every single prescription that is written for an erectile dysfunction medication. Most of those prescriptions are written with the full knowledge that this is not a covered benefit under somebody's health plan. And yet that person, that patient, wishes to pay out of pocket. If you prescribe that medication, because it is also covered for certain circumstances for like hypertension, then you have to go through the whole prior approval process to put in that you're prescribing it for erectile dysfunction, just so that you can get the denial, so that the person can then pay out of pocket for it. So, you know, when we're including in all these denials where the insurance companies are saying we're saving this amount of money, there is a pretty big cohort of prior approvals that have to be put in just because it's required, even though both the patient and the provider are well aware that it is not going to be covered. And you just have to jump through that hoop in order for the patient to actually pay out of pocket for it. And I did want to make one more point, that I actually contemplated it at one point because the bill wasn't moving as well as I wanted it to. I thought about scrapping the whole thing and making it so that all prior approvals need to be on paper in triplicate, faxed to the insurance company, and that the insurance company then has to input all of the information, and that they have to do that within 24 hours. Because frankly, I think that would eliminate more prior approvals than anything if we'd go back to the way it used to be.
Jessa, I would like to turn to you now. So Alyssa Black is unusual in that she's an elected member of our legislature, appropriately got herself on the health committee, and she's obviously has a sophisticated understanding of what's going on, certainly in primary care. And that's really unusual. Most legislators are going to have a whole lot less background. You've been serving as a person who deals with legislative government interaction, government relations on behalf of doctors, medical societies now for well over a decade. How do you approach legislators who just don't get it? Like most doctors just don't have the time or energy, or they may even be intimidated or whatever in going to legislators, but do need an advocate so that this kind of issue doesn't get delayed year after year or even happen at all. So how do you interact with legislators who just don't have real knowledge of the issue? What do you do?
Thanks. So I would encourage everybody on the call, if you haven't already, to look up your medical society in your state, because every state has a state medical society. And one of our jobs is to sort of bridge that voice of medical students, residents, physicians with policy makers, whether it's the legislature, administrative agencies here in Vermont, the Green Mountain Care Board. And we do that in a variety of different ways, depending on the issue, depending on where it is in the political process. It may be sending out emails, to get our members to send email messages. It may be identifying a specific physician like Dr. Marvin, who's really involved and knowledgeable and articulate on an issue, to come testify in the legislature. It might be, we here in Vermont, and I think many medical societies do this, having roundtable meetings with candidates in the fall before the election, come meet your candidate in your district. So all sorts of ways. I mean, we think of one of our jobs as kind of following the progression of an issue and then knowing kind of when and where to plug in the physician voice most effectively. Contact this committee today. Next week it might be contacting the next committee the bill is in. Then it's contacting the governor. Because that is the part that's really hard to follow for somebody sort of doesn't have the time, frankly, to be in the legislature. Very often, you may really know a content area, you may know the clinical information, you may know the policy you want to advance, But to know kind of how a bill is moving or which lawmaker to speak to at which time can be really hard to follow when you're not there. So medical societies have policy experts, they have lobbyists who can help you know sort of when the right moment is to take certain action. And, here in Vermont, where I heard some, I think most of the states where you're all located tend to be bigger. We haven't talked about the fact that Vermont's legislature is a citizen legislature. So again, to Marvin's point, it is pretty unusual to have somebody who's so expert in an area because, our lawmakers, it's not full time. It's, from January till usually May. They have other jobs. They have real lives outside. They don't have staff. They have one attorney who helps draft legislation for split between multiple committees whose job is to sort of say, okay, if you want to accomplish X, here are the words to put on the page, or here's a report that could inform this bill you want to write. But they're really not there to give policy advice, to say, oh, that's a horrible idea. You tried that 10 years ago and it did not work. Or, there's no way this is going to get passed this year. That's really not their role. They're supposed to be pretty, non-biased, pretty impartial. So I think, and I'd be interested to hear Representative Black's perspective, it means that legislators really do need to rely on not just advocacy organizations, but witnesses and people like you to come in and say, here's how this would impact my career. Here's how this would impact my work with my patients. So we had a number of hearings on this bill. Katie testified a couple times. We had a dermatologist who runs her own very small private practice who could really explain, here is how I bill and code. Here is how I submit a claim. Here is how this policy impacts my ability to care for my patients. Here is how it's bad for patient care because I can't see, if I'm a dermatologist, I see a patient with a mole on the same day they come in for a mole check. I can't get paid if I remove that suspicious mole on the same day. So I have to have the patient come back. And that leads to, stress, poor care, not the right thing for the patient. So those are all the pieces that we try to put together and try to make sort of tell a story and give the backup to the legislature.
Yeah. So, Dr. Marvin, I'm wondering, both of you, Jessa as well, is it so many I don't know of any doctors who enjoy prior authorization going through it, and most find it to be annoying. And, in my case, I feel like it's a hypertensive effect, which is extremely annoying. But anyway, having that feeling and then getting doctors to do something are two different questions. And interestingly, you used the word apathy before, which surprised me. That this kind of administrative intrusion into your workday leads to apathy. But it seems like apathy when the doctors who even feel strong about something when they don't then act. Like, what strategies can get people to actually do something? What are your
I've been
thoughts?
thinking a lot about this. I think if we were more visible and more present, Jess and I have talked about this a lot. I think we would be able to influence things even more and in even better ways. It's like the what's that saying? Like the woodsman who doesn't have time to sharpen his axe, you know? So, it's hard to cut out time to make change, but it's needed. I really appreciate the fact that like the team that we work with at VMS, led by Jessa, I trust them. They've done all their homework. Like they tell me like what the data is, what is happening. Like they listen to my perspective and might include some of my thoughts, but they'll sort of direct me like, okay, well, we've heard your 5 things. This is the one we think you should say. This is going to get the most mileage. Like I really think that they've helped guide like what needs to be said because I don't always know the intricacies of the bill as well as they do. So they have, quite a lot of power in a good way. And I think that trusting them has been an important part of my strategy. I will cut out time. I will put, even use time off, like my vacation time off if I need to kind of block out an afternoon. But one of the cool things about Vermont is, I could drive to the State House from here in 20 minutes. I'm a part-time doctor. I have 3 kids I take care of, and I can still go down there and like shake hands with the governor and tell him a 30-second story and be back for clinic at 1. So like that's really interesting. And I think Vermont's a good place where a lot of things can be tried. It's fairly progressive, it has a fairly low population. So, wasn't it like Dr. Dinosaur started here and a few other things? I might be wrong about that, but I feel like this is a good testing ground for some things just to see if it works with our population. Um, but I really do trust the VMS leadership. It was important to have Alyssa in there because, it is true that every time I've ever testified to any of the committees, I'm shocked by how little they know about medicine. And it's no insult of theirs. They're just, this is what I do. It's not what they do. And I remember testifying one time about an audio only bill. And I was saying, like, listen, if I'm on the phone for a half an hour with a patient, even though I don't have video, we've made decisions. I might have made a referral. It's time. It's a lot of time. Why is that not valuable as an actual visit? And I remember one legislator, she said, well, listen, I don't want to pay for every single phone call that I have with my doctor. And I was like, don't worry, we're still going to do a lot of phone calls for free. But these are the long ones where we're like making decisions. This is an actual visit. And not to mention, like lawyers do this every day. So, just kind of calling them out a little bit and saying, like, listen, like, let's make some distinction between like my random phone call where I'm talking with somebody about their thyroid lab and a 30-minute phone call where I'm changing around their medications and ordering labs and making referrals. Like, those are 2 different things in my mind. And I feel like it's fair to ask for reimbursement for the second. So I feel, and that was like news to them. You know what I mean? It was good for me to be able to recognize that this is just something they never thought about before. And for me, it's just my everyday thing. So I think it's become very rewarding for me. I like teaching in general, so I sort of feel like I'm in the role of teaching a little bit and saying, hey, what questions do you have? Where can I clear things up? What are your worries about this moving forward, and hearing their thoughts and trying to clear up any little nuances that might make a difference.
Yeah.
And I just
Representative Black, I'm wondering if you could describe what the process is like for other members of the legislature who don't have your background. Do you ever hear them voice the feelings that they just don't know enough, so it's easiest for them just to not do anything? Like, how do you, and I guess included in that question is what approaches have you seen that seem to work best versus not best for someone like Dr. Marvin or Jessa?
Well, I will say that I'm very lucky to be on the healthcare committee. The majority of members of this particular committee have no experience whatsoever in the healthcare realm, but that doesn't mean we don't try. I mean, there's an awful lot of topics that I know nothing about, which you think you know everything, and then an hour later you realize, oh my gosh, I've never even heard of that before. So it's a constant learning process. We are a citizen legislature, so we know that we don't have expertise on things. And I know every state is different. Every state is completely different in how they move legislation. We have a very collaborative process. A bill can come as just a sentence. It can come fully formed, and we will spend, sometimes weeks just taking testimony, and we can change things around. To Dr. Marvin's point, we try to, which it sometimes frustrates me a little bit. Every single bill we do, we hear from every single possible viewpoint on that we can. And unfortunately, what that leads to is that we hear the same, and no offense to Jessa on here, because I love Jessa. We get talked at by professional lobbyists and basically professional witnesses. So sometimes all day long we can do one bill, and we're hearing from the exact same people that we hear from every single day on every other bill that we do. And there is nothing more refreshing than someone like Dr. Marvin coming in and saying, oh, here, let me tell you what real life is. And the audio only telehealth that we did, I can tell you she's exactly right. I mean, people don't really have a concept. They just think phone call with your doctor, that's you calling up saying, I need a prescription refilled. And so there's a lot of education that goes around that. But I will say that I think I really do think that most of us try very hard to understand something. And if we don't necessarily understand something fully, most of us have people that we trust, that we know do understand, and we trust them. I cannot be an expert on every single thing that I vote on. I can't be an expert on 5% of the things I vote on, but I have people that I trust, and I trust the process that those people are doing the due diligence that needs to be done. And I think even though everybody on our healthcare committee doesn't have expertise, I think when we hear from a diverse set of witnesses and we try to take as much testimony as possible and we try to understand a topic, I think we do pretty well in the end.
One last thing on that I've noticed is everybody's, even if they don't have healthcare experience, everyone's been a patient, or had a family member with a frustrating patient experience. So trying to relate to that and understand where their frustrations have been, and maybe tying that into a topic is helpful because people can relate to that. And then the second most important thing I've kind of recognized is that cost is always going to be a big factor. So if at least in my mind, if I can sort of justifiably and with evidence say, like, look, I really don't think this is going to cost more. I think this is actually going to save people a lot of time, and that equals money, or it's going to improve health, and therefore it might be worth the investment. Like if it's in dollars, that's why getting that data is so important. So you can actually sort of stand on some facts with the dollars. It's hard to get the data sometimes, but anything where you can sort of actually relate it to a financial burden versus improvement is going to help get people's to pay attention.
And I will say that I was very successful in lobbying my fellow members in frankly both the House and the Senate, even though they didn't necessarily understand this bill. Almost everyone has a bad prior authorization experience. And that's what people kept coming back to.
Yeah. So what approaches have you seen advocates use that really are counterproductive or ineffective that novice advocates might be using?
I would say never threaten us. That's somebody told me once, a lobbyist, long before I was even in the legislature. We have, as Jessa had pointed out, we have no staff. So we really do rely heavily on advocates and lobbyists. I always say that, if you hate lobbyists, don't forget that there's an equal and opposite lobbyist lobbying for the thing that you love versus, the person opposed to it. And the most important, I remember he told me that the one thing I can never do is I can never lie to a legislator, or I can never give them incorrect information. Because when somebody is relying on your information that you're giving them, and that information turns out to either be not true, or it's just some sort of fallacy or it's an exaggeration, you have then lost the trust of that legislator. And so, trust is the biggest thing. And frankly, I think one of the reasons we were very successful with this bill is because, we talked about being able to get appropriate data. The data points and the money that was given to us were so wildly inaccurate and changed every day. I mean, I remember one day they came in and said it's going to cost $100 million. I think a couple days later it was $6 million. I mean, what it was like, just throwing bombs to scare people. And that's what I mean when I say don't threaten us.
And
don't
Alyssa,
don't throw bombs.
yeah, I mean, I'll tag on this, and then I see Selen, you have your hand up, but this just tees in with what Alyssa was saying. I don't know that we have, and maybe Jessica can, you say we have equal and opposite sort of lobbyists on both sides of an issue, but I don't really know that they are all equal and opposite or equal. We were testifying on this with the help of VMS and you and a lot of other doctors that wrote letters and things, which was really, really, really important. But there were lobbyists like calling my husband's business and asking him to testify against me because he employs, quite a few people in our town. And that's a lot of lobbying power if you've got the bandwidth to stretch yourself and call every business owner in Vermont or however many business owners they called. Like that's quite a lot of dollars that I don't think we were able to compete with. So it was really those stories and the testimony that Jessa and VMS really rallied, like really, really rallied people, called, encouraged, said, write a letter, here's a suggestion. And they're constantly giving us the phone numbers. Here's the phone number for your rep. Here's the phone number for the governor. Here's the place where you write it. And that's extremely helpful for people that are just tired, busy, maybe have a few minutes, and want to do it, but like maybe it's going to slip through the cracks. Having those constant encouragements is extremely helpful. And I'm sorry, Selene, I just jumped in front of you, but
Go ahead,
Can
Selen.
I just expand a little bit on that? Because I just wanted to jump off of something that Dr. Marvin said. I will say VMS, Vermont Medical Society, did an extraordinary job, along with multiple other advocates for organizations that represent hospitals, healthcare providers. There was a concerted effort, and one very important thing, and Dr. Marvin, I'm the one that gets every single one of those emails. I got them from the business owners when the insurance companies started reaching out. I got them from the business owners. I got them from you and your colleagues. The most important thing is none of them are canned. Every single story that every single doctor told me was an original story. And the fact that that physician took their time, because I know how little time they have, that they took the time and it was such an important issue to them, that weighs so heavily. That is much better than a canned response from some member of a chamber saying, don't raise my rates because the insurance company told you to send a canned letter. So anyways, thank you for your letters and your testimony.
Selen, finally, go ahead. Thank you. Selen, go ahead.
Sure. I was just curious to hear, and my apologies, this is maybe too Vermont focused, but when considering populations like Essex and Stowe, and even more rural places as well, and then comparing that to Burlington, in terms of age of population and also like housing status and a lot of different things that Burlington specifically deals with, how do you find that advocacy, or if you have, has differed between targeting like those two different kinds of populations?
Do you mean targeting legislators from those communities or issues that impact those communities?
Kind of both. I was just thinking more in the approach, just considering the problems that each of these communities have are pretty different. If that's too big of a question, my
I can give
apologies.
you an example that has come to mind a couple times that might highlight that. I mean, I trained in Burlington, but work in a more rural community. So, and I do a lot of work in the field of substance use disorder. So, for example, where there was a bill which was being discussed about, safe use sites, and it was highly contested, right? What do we do? What do we do? And I think that's a good example of where the right answer depends on where you are, and that's how it finally landed. It's not a great option for a really rural community. It's a great idea as a testing zone in a more urban community. But you're going to hopefully you get a diverse amount of testimony from all those different places. And then the legislators kind of have to recognize that they're sorting through it. And a lot of the perspectives are reflective of that provider's community specific issues.
I was going to go back, and it kind of relates to that a little bit. But I wanted to also address Marvin's question about you have, I guess, framed it as what's not as effective, but I would flip it a little bit to an effective strategy. I think you have to come with a really concrete and implementable solution. Has been my experience, that it's easy to lay out the problem. But if you have a really, and I'm mentioning this in part because I know, some of the interests of your, the organization, why you're doing this internship and sort of health reform, which is a huge topic. But if, any legislature, but particularly a citizen legislature, but many states have only, legislature that meets only part of the year, or bills that move really fast. And if, I think I have seen the strategy be much more effective to come with implementable steps towards a bigger solution than, we are going to solve this all this year, especially if it is something expensive or that needs to be studied. And that's one of the reasons really that led to 766 is, could we have just said, get rid of all prior authorization? Is that what our, especially primary care, wants to see? Is that what our, our membership wants to see? Yes. If we had come forward with a bill that said end prior authorization, I think it would have been dead on arrival. But we really picked, and the stakeholder group that Alyssa mentioned, we also built a coalition to work with us. So it wasn't just VMS, it was the Hospital Association, the Federally Qualified Health Centers, our Academic Medical Center, so we worked on a bill before session with some sponsors, and it, to try to be really targeted with, here are our specific solutions that we think, and other states have tried some of them. So we think they can work, and here's the data behind each section, to make it something that could actually move along with the support of champions and our membership and all of that. So that's just my 2 cents on a strategy to really help move something forward.
I would like to move on to a related topic, but not do so until all the questions about this particular bill and its legislative journey get answered. So any of the interns have other questions about what we've discussed so far?
I guess I do have one question about this particular bill. Because I think it was mentioned earlier that this bill targets mostly prior authorizations for imaging. So I guess related to what you're just talking about, is this kind of seen as like a stepping stone for a later bill for like maybe reducing the prior authorizations for medications or like other realms? Is this kind of like a stepping stone towards that? Or is that in the foreseeable future?
And, Jessa sort of alluded to this, but the bill started much bigger than, which all bills do. And there was a stakeholder group, everybody working on this together. Some not so much. I was very, very clear at the very beginning of this that I was willing to whittle it down to something, but I wasn't going to get rid of certain things. Because I wanted to do something concrete and, really do something important. Frankly, I got a lot of criticism afterwards from providers. I got a lot of emails from providers that said, what about me? What about me? It is, I see all of you. You start small, changing the story of how of how things work, it takes a long time. And you know what? We start small. It mainly affects prior auths for imaging because there are certain categories. And I mean, I would love to eliminate medications, but that's very, very difficult to do because of pharmacy benefit managers and formularies. So you're not talking about prior approvals based on medical, medical decision makings. You're really talking about every single insurer has different financial obligations to different medications. So, the goal is to start small. We had a big compromise in the Senate, which got us to eliminate primary care only. Better to do that in the Senate than have the bill die, which is probably what would have happened. And you know what? Every year I will come back with more. And that's just sort of, you just start moving the needle. And hopefully in 2 years when we get these reports back, we can say, see, it didn't actually increase utilization. And then we can start chipping away at other things. But it takes, again, I said I worked in healthcare administration for, well, it's been almost 30 years. And I've seen every single incarnation, and they all sort of ebb and flow and come and go. And I'm just sort of hoping that we're coming to an end on this.
Well, you mentioned stakeholder groups. What is that? Is that commonly done for many issues, and does it include legislators or just advocates? I never heard the term before.
I think it's common on almost everything. I will tell you, we very, very rarely put out any bills that do not have consensus from all parties. This bill was a little bit different. I mean, maybe Jessa can disagree with me. There's always going to be somebody who's not happy with certain parts of it, but we really, really try to work hard to make sure that everybody is getting what they need in a bill so that we have consensus. We want that. So stakeholders our stakeholder groups included hospitals, payers, and VMS, some other provider groups, independent practices, pretty much everyone that kind of has a stake in our healthcare system. And, you try to reach consensus. This bill we knew that there were certain parties that weren't going to be happy, but we were able to give them a lot in this bill that they were pleased with. So, we try to do that with everything.
And I'll say that plays out really differently in different committees and different bills. I would say, so some bills, it's, the committee just hears from the witnesses and tries to kind of then put out a draft maybe for folks to respond to, and they could come testify again, sort of on the next stage, and feedback again on whether they do or don't like the draft. In this case, in the House Healthcare Committee with this bill, we literally sat around a table for two or three meetings with legislators, with all the anybody, the organizations involved who wanted to comment on it, to try to come up with a next draft. Sometimes it means there's like a stakeholder group over the summer or fall. So if a bill can't reach consensus in a session, it may be that there's actually a report or a group who's going to work on it in the off session and come back with new language the next year. Sometimes it's just the advocates, like VMS worked with some of our other healthcare associations leading into this session to come up with a first draft of this bill. So there's all sorts of ways, but one thing I would say is you need to have allies, in whatever you need to do it alone as one interested physician, one interested organization. It can be really hard to move a bill. So always look for other organizations, folks out there to work with you, partner with you, who can help move something along.
Okay, so before we adjourn, we have the current president and the executive director of the Vermont Medical Society here. So I would like to at least have a little bit, at least a brief discussion about medical societies. And let me just say my since I'm probably 20 years older than Dr. Marvin, I have different thinking about the American Medical Association and some of its actions during the 1940s, 50s, 60s, which were largely obstructing access to care for many groups. And like the civil rights discussion we had this morning, like the AMA pushed to have Medicare Part B not require integration. And that was the physician part of Medicare. Anyway, but what I'm getting at is that I came away with kind of an anti-AMA bias and from that history. But that's history. I mean, and let me just say the other thing that the AMA did during those years, the 50s, was create fee schedules so that specialists and procedures were paid much better than primary care physicians who were working doggedly, very hard and required a good deal of skill, finesse, all that you need to be a high quality primary care, doctor. Anyway, so those are my biases, but that's history and now is now. So I guess and if there's something immutable about what I said, like does the AMA or the Vermont Medical or any medical society is immutable, is incapable of changing. And so I guess I would like to give you a sense of what most medical societies, whether it's Maine or here, or how you welcome a sort of a turnover of ideas. Like this group of medical students seems really interested in the pharmaceutical industry. And next week they're going to learn about PBMs, pharmacy benefit managers. They're likely to be horrified and disgusted. And they're going to maybe want to do something about it. So rather than just sort of say, well, I'm disgusted by this, I'm going to fight this battle alone. How do you engage other doctors to start focusing on an issue, and what's the role of medical societies to debate and to come up with new positions and advocacy elements?
Yeah, what a great question. I'll start because I can maybe be a little bit directly addressing the AMA piece, which is that I was new to the AMA policy setting when I came into my role as the executive director, because in that role, I accompany our state delegates to the National American Medical Association meetings. They meet twice a year with what's called a House of Delegates. So there are representatives of states and specialty societies at that meeting. And I came in probably with some of the same sort of historic sense of AMA policy. And I was extremely impressed. Not that every decision came out the way our Vermont delegates or even our New England delegation thought it should, but the sense that the student section, the residents, the young physicians, the women's section is having a much, much stronger and louder voice and forcing the House of Delegates to wrestle with some tough issues, to take different positions. You maybe followed a couple, this was now probably 4 years ago or so, came extremely close to withdrawing their opposition to single payer healthcare, largely due to the organizing of the students and residents and young physician groups. So I do think medical societies change. Medical societies reflect their membership of their governing body. I think one of the issues with the AMA House of Delegates itself is that states determine how they select their delegates, and many states don't have term limits for those delegate seats. So there are, many physicians who have been in those seats for decades. But that is definitely changing. And I think I would not shy away from being involved with the AMA or other national specialty societies. It is an extremely good training ground for learning about Robert's Rules of Order, how to get a resolution adopted by a large body. And then I think other state, I can't speak for every state medical society. Every state medical society is different. And that's actually one of the interesting things about going to the AMA meetings. It's like a mini Congress. So you get very diverse viewpoints, very diverse politics. You hear the issues that are resonating with physicians in Texas and Florida as much as Massachusetts and Vermont. So it's fascinating. So I'm sure those medical societies have very different policy positions on things, but they all have a process for adopting state-based policy as well. And whether that's through their board or through a House of Delegates at the state level, students usually can submit resolutions. They can work, you can work together as a group to bring forward a policy idea. I would certainly recommend reaching out to medical society staff first to just confirm things like, does the state already have a policy on something? What's your process? How do I go about introducing a resolution? That's usually the process by which then that state can set a position on an issue that could then lead to, say, introducing legislation or supporting policy change at the state or AMA level. So that's my, I think it's definitely not, I think people shouldn't shy away from getting involved in medical society politics, even if it currently doesn't reflect your perspective on something. That can absolutely change.
I mean, I'd like to add to what you're saying. I think the Vermont Medical Society has allowed discussion, and if you want to do something about PBMs, for instance, put a resolution to your state medical society. They'll probably have a student section of some sort, and make them grapple with it, make them think about it. I'm sure they'll be learning, because the business practices of many of these companies are not broadcast to the public. So anyway, I think it's an educational tool as well. Kate, Dr. Marvin, any more comments from you?
I think I'm technically the vice president.
I'm sorry, I got your
Until
title.
November.
Then you're president.
I was the president of the Vermont Academy of Family Physicians. As Jessa said, I was lucky enough to go to a couple Congress of Delegates representing Vermont. And as she said, it's very fascinating to hear different perspectives of family docs around the country. And we share so many things. We share so many strengths, but there are some significant differences that I'm sometimes taken aback by. And so one of the things to think about is, we see what it's like on the ground for patients. So regardless of our personal opinions or stance on something, if you really think something's important to your patient population as a whole, you're really representing them. And there is absolutely no guarantee things are going to go in the favor of what they need unless somebody's advocating for it. And you're the person that knows what they need the best. You're the expert in the room on the medical side of things. And there might be a whole area that needs improvement that no one's even really thought of a different way of doing it yet. So I found it to be pretty rewarding, just because it's fascinating to hear those different perspectives. It's a little scary sometimes to hear those different perspectives, because we live in such a little, especially in northern Vermont, for the most part, fairly insulated, fairly liberal state. And I think it's also really uplifting from a family medicine standpoint to think, wow, there are 120 really smart, powerful, awesome family doctors in this room. It's going to get better. So it also provides me with a little bit of hope, because I think if there's all these amazing people in every single state, all sort of chanting the same, we're going to make the system better for our patients and for ourselves, then it leads me to believe that it will be better. I want to end with one thing, though, because I sometimes feel like students in medical school, especially mostly in urban medical schools, tend to be specialty driven, get this hidden curriculum, anti-PCP family medicine vibe a little bit. And we've been talking about all the brutal stuff with family medicine today, the time, the administrative burden, the prior auth. And I just want to make sure a 30-second soundbite that family medicine is unbelievably rewarding. So, I take care of 4 generations of people. I see them in the grocery store. It's, if you survey people at sort of towards the end of their careers, if they get through the first 10 years, they are happier than most subspecialists. I think in terms of their true job satisfaction and connection to their community, and also the diversity of skills that they can continue to maintain throughout their career. So I just want to put a little flag up there for primary care and family medicine in particular, that if any one of you ever want to come up and do a week, just give me a call. I'm happy to host anybody. It's been shown that if you get your foot in the door, sniff around, see what it feels like actually on the ground, that you're more likely to consider it. So just think about it. I've converted a lot of people.
Well, thank you so much. I think with that note of both optimism and support for primary care, it's a good spot to end the session. But I want to thank all of our guests and as well as the interns for their attention. But I just really appreciate the members of this panel, Jessa, Dr. Marvin, and Representative Black. It's so nice of you and to take the time to educate the next generation of physician leaders and other healthcare leaders. So thank you so much.
Thank you. Thank you for having me, and good luck next week on PBMs. What fun you're going to have.
Thank you all. Nice to talk with you.
Take care.
Good afternoon.
Take care.
Thank you.